Welcome back, friends. As the part of our continuation of our course of anatomy 100.01, today we are going to discuss with the nerve supply of the upper limb. So the upper limb nerve supply it is through what we call brachial plexus or brachial plexus. So calling brachial or brachial is just pronunciation, but this is how it is written, is brachial plexus. Now what we are discussing mainly about the nerve supply of the upper limb is how the brachial plexus is formed, its roots, then its divisions, its cords, and until the final branches of the brachial plexus. And each branch of the brachial plexus supply which part of the upper limb. Then later we will end up with the discussion about what are the disorders or the clinical conditions in which we may have paralysis of a certain branch of brachial plexus. Now, function of the nerve which are entering the upper limb is the sensory innervation. That means you are taking the sensory information from the skin of the upper limb and from other parts of the upper limb to the central nervous system of the either skin or deep structures. Also another function is the motor innervation to muscles, So these are the two major functions. This is the function of taking information from peripheral to the central nervous system, but this is motor innervation to the muscles in the function of taking commands from the central nervous system to the muscles of the upper limb, which perform different functions of the body. Now the brachial plexus is formed in the posterior triangle of the neck. So we'll study about the triangles of the neck when we'll be studying about the head and neck. But what you need to know here is that the brachial plexus is formed in the posterior triangle of the neck by the union of the anterior arm of the spinal nerve from C5 to T1. So as we know that we have about 30,000 spinal nerves, so the combination or the union of the anterior arm or the anterior branches of the spinal nerves from C5 to T1, they form what we call the brachial plexus. So when we are saying the union, it doesn't mean that from C5 to T1 they join and they form one nerve, but it is a kind of interconnection. One root can interconnect with another root to form divisions, to form cords, and then later will form the final branches which will supply the upper limb. So the roots they are from C5, C6, C8, and C5, C6, C7, C8, and T1. So we have 5 roots here. Also we have 5 final branches of the brachial plexus, or the final nerves from the brachial plexus. They are also 5, but it is not a direct that from C5 will form a certain nerve. So because there is interconnection of nerves, that's why we call it the plexus. The plexus. Brachial, it is because of the region where it occurs. That's why it is called brachial, because in this region we have brachial artery. We have so don't you wonder, the word brachial is just because of the anatomical region, and plexus is the interconnection of our nerves. Now this is how the brachial plexus appear in the neck region. As I told you, it is in the anterior triangle of the neck, and it is formed by the combination or the union of the anterior arm of the spinal nerves from C5 to T1. Now as you can see here, we have the anterior scalene muscle, and here is the middle scalene muscle. So as we know, we have the anterior scalene muscle, middle scalene, and posterior scalene. In between the middle scalene and anterior scalene, we have the brachial plexus. During dissection of cadavers, this is very important for you to know, because if we cut this muscle and if you don't know where the subclavian artery have passed and the brachial plexus have passed, it will be very difficult for you to appreciate or to see these structures by your naked eyes, because what we are doing in dissection of cadavers is just the studying of what we studied, or is just the observation of what we studied in the gross anatomy. So the position or the point where the subclavian artery passes above the first rib above the first rib. This is the first rib, so it passes above the first rib, and then it comes to pass below the clavicle, passes above the first rib, behind the anterior scalene muscle, above the first rib, and below the clavicle. The brachial plexus is above the behind the anterior scalene muscle, above the first rib, and below the clavicle. This is how we can describe the position of the anatomical position of the brachial plexus in the neck. So in the neck region, brachial plexus passes between anterior and middle scalene muscle, anterior and middle scalene muscle. So brachial plexus in the shoulder region, unaweza kuona how in the shoulder region the brachial plexus appear. It forms an M-like shape, I think you can appreciate this shape. You can appreciate this shape. Comes from here, goes up, then it goes down, then it goes up again, goes down. An M-like shape. This is how brachial plexus is. However, it have other branches. For example, this one, which goes to round the deltoid muscle, goes to round the humerus and perform the nerve supply of the deltoid muscle. So what I'm talking about here is that this is the appearance of the brachial plexus, at the shoulder region. So as you can see, it passes above the first rib, then below the clavicle, and then it passes in front of the scapula. It is how. So as it enters the upper limb, brachial plexus pass above or superior the first rib, below the clavicle or inferior the clavicle, and in front or anterior of the scapula. Again, this is how you can see where the brachial plexus. Again, the M-like shape is here. So we shall see later what are these branches of the brachial plexus which form the M-like shape. So unaweza kuona hapa, this is the simple diagram explaining about the brachial plexus. Very simple diagram, and it is very easier to be understood by everyone. Now we have root C5, we have root C6, we have root C7, and we have root C8 as well as T1. So from these roots, the root of C5 and C6, they join to form a superior trunk. Then C7 continue itself as its own, it forms the middle trunk. So from roots we have trunk. We are forming trunk. So from C7 you are forming middle trunk, and from C8 and T1 you are forming inferior trunk. Now from the trunks, each trunk have two divisions. Anterior and posterior. Each trunk have two divisions, anterior and posterior division. So look at this side of division, look at this column of division. Then all of the posterior division, they join to form the posterior cord. All of the posterior division, they join to form posterior cord. So posterior division of the superior trunk form the posterior cord. Then posterior division of the inferior trunk and that of the middle form the posterior cord. Anterior division of the middle and the superior trunk form lateral cord. Anterior division of the middle and the superior trunk form lateral cord, while the anterior division of the inferior trunk form medial cord. From cords we have the terminal nerves. So how the terminal nerves they are formed? The lateral cord divided into two branches. One of the branch from the nerve, but another branch join with the branch from the medial cord. So the branch from the medial cord go to join with the another branch from the lateral cord to form the nerve, the terminal nerve, and then the posterior cord form the terminal nerve is itself, and also the medial is divided into two branches. So the lateral and the medial, they are divided into two branches each. One branch go to form the terminal nerve, another branch they join, two branches they join. So we have five roots, and then they are dividing themselves into trunks, into divisions. In divisions, every nerve just divides into two divisions, but the divisions they are joining in a different version to form the course and then the terminal nerves. So yeah, let's go to the next slide and see how our discussion continues. So this is again the explanation of the same thing which we have explained in the first diagram. What we have explained in the first diagram, we have C5, C6, C7, C8, T1. So C5 and C6 they form the upper trunk, middle trunk by C7, and the lower trunk by C8 and the T1. From there, upper trunk form the anterior and the posterior division. Each of the nerve form the two divisions. All of the posterior division they form the posterior branch, and this posterior branch continues, as we have seen in this diagram. Posterior branch continues, itself forms the terminal branches. So posterior branch goes to divide into two terminal branches, the radial nerve and the axillary nerve. Radial and axillary. From the posterior cord. Posterior cord forms the radial and axillary. So from here the posterior cord will go to form two terminal nerves from here, from the posterior cord, which is formed by the combination of the posterior divisions. Also from the medial which is formed from the anterior, as you can see here, the anterior division goes to medial, and then from the medial direct it forms the terminal nerves. So from the medial we are getting the ulnar nerve, but also the medial tend to give the branch which join the branch of the lateral. This is the median nerve. So the median nerve is this one. As you can see from this diagram, this is the median nerve. So we have the ulnar nerve here from the medial. We have the median nerve, which is the joining of the branches of lateral and medial cords. Also we have the musculocutaneous nerve. We have the musculocutaneous nerve. So from our previous slide, which is this one, you can see one thing, or you can observe one thing, that this one will go to form the radial nerve and axillary. Here will form the radial and axillary. This one will be musculocutaneous nerve. This one will be ulnar nerve. This one will be the okay, I forget it, but one thing which is important for you to understand is this will be median. So median nerve, musculocutaneous, ulnar, and actually you can't remember everything here, but it is important for you to remember some of the few things. For example, in this M-like shaped structure, we have musculocutaneous, median, ulnar. Musculocutaneous starts with M, musculocutaneous, median, then ulnar. But also you can remember an easier way to memorize here. Median, it is also middle, at the middle of this M, median nerve, middle of this M, median nerve. So musculocutaneous at the start of M, median, then ulnar, because this posterior forms the radial and axillary. It is important just to remember the terminal branches and how they supply the upper limb and their functions or the clinical cases in these nerves, but it is not very important for you to remember all of these divisions and the combinations. However, if you have a lot of memory in your head, if you want to memorize them, no problem, it will be better. It will be better for your good performance of the exams. Now let's continue. This is how we can say the chords give of the branches in axilla. So in the axilla region of the upper limb, lateral cord inatoa lateral pectoral nerve, lateral cord inatoa lateral pectoral nerve, musculocutaneous, and the lateral root of median nerve, So unaona hapa tumesema lateral inatoa musculocutaneous na median. So that means median nerve ina root mbili, ina lateral root and median root. But at the axillary region also it gives off the lateral pectoral nerve. Lateral pectoral nerve haijawa indicated in this chart. So we have musculocutaneous, lateral root of median nerve and the lateral pectoral nerve. From the median cord we have the medial pectoral nerve, medial pectoral nerve, medial root of median nerve. That means medial root of median nerve and lateral root of median nerve, they combine to form the median nerve. Then we have medial cutaneous nerve of arm, medial cutaneous nerve of forearm, medial cutaneous nerve of arm, and then you have medial cutaneous nerve of forearm, then you have ulnar nerve. So unaweza kuona kwamba tunaposema median nerve it has two roots, which are the medial root and the lateral root. But in terms of medial nerve, for example, this is called the lateral pectoral nerve. It is because it is the division of the lateral cord. But here we have the medial pectoral nerve because it is the division from the medial cord. Then you have the medial cutaneous nerve of the arm, medial cutaneous nerve of the forearm. All of these, it is because they are divisions from the median cord. And then we have the posterior cord. In the posterior cord, as we said, the major branches, they are axillary and the radial nerve. But you have other nerves. For example, you have the lower subscapular nerve, thoracodorsal nerve, and upper subscapular nerve. So some of the branches, they are lower or they are smaller branches of the brachial plexus, but they are very important because in your dissection you'll come to encounter a nerve like thoracodorsal nerve, or you will come to encounter some of the nerves, and then you will not know where are they coming from. In my gross anatomy I didn't study about these nerves. If you know only the 5 terminal branches of the brachial plexus, it will be very difficult for you to know where are they coming from. But if you know that there are other small branches such as thoracodorsal nerve, and then some of the branches like upper subscapular, medial pectoral nerve, medial cutaneous nerve of the forearm, then in your dissection of cadaver you will not encounter some of the challenges. So what I was saying that brachial plexus can be divided into roots, trunks, division, and cords. This is an explanation of what we have already said. The upper 2 roots, C5 and 6, unite to form upper trunk. The roots C7 continues medial trunk, and the lower 2 roots C8 and T1 unite to form the lower trunk. Each trunk divides into anterior and posterior division. Each trunk divides into 2 divisions. All posterior division of the trunk unite to form the posterior cord, which divides into 2 nerves, axillary and radial. Axillary and radial. But the anterior division of the upper and the middle trunk unite to form the lateral cord. Lateral cord divides to form musculocutaneous nerve and the lateral branch of the median nerve, also lateral pectoral nerve. Also we are saying that the anterior division of the lower trunk continues at the middle cord, and the middle cord divides to form the medial branch of the median nerve and the ulnar nerve. So unaweza kuona hapa, this is a diagram which shows how the brachial plexus equal. Now this is within the body. This is the drawing of what actually happens in the body. So you can see here we have the C5 and C6. They join to form the trunks. So here we have the superior trunk, then C7, then C8 and T1. From there you can see this joining. From there all posterior they join to form median cord. All posterior they join to form median cord. I mean all posterior division they join to form median cord. Then the 2 anterior they form lateral cord, and then the 2 I mean the one of these anterior, one of it continues itself at the, this is we have all of these, they join to form the median cord. Then, so what is important for you to know here is about the terminal branches. All of these divisions, they form the terminal branches. So major terminal branches, we have the musculocutaneous, median, ulnar, radial, and axilla. Musculocutaneous innervates the biceps brachii and some overlying skin. Actually, musculocutaneous, it doesn't only innervate the biceps brachii, but innervates the anterior compartment of the arm, that is biceps brachii, then coracobrachialis and brachialis muscle. All of these muscles, they are innervated by the musculocutaneous nerve. Now, the injury to musculocutaneous nerve will affect more flexion of the arm. Flexion of the forearm will be affected because of the injury of the musculocutaneous nerve. This is because the flexion of the forearm is movement which is controlled by the biceps brachii with other muscles of the anterior compartment. From there we have the median nerve. Median nerve innervates anterior forearm muscles, some intrinsic hand muscles, and the skin of the lateral. If we put the hand in the anatomical position, lateral, it is towards the thumb. So median nerve inaanzia huku, kwenye anterior compartment of the forearm, then naenda mpaka kwenye, tenda kuona huko mbele kwenye dermatons. Lakini from there we have the ulnar nerve. Ulnar nerve innervates intrinsic hand muscles and of the medial hand. Intrinsic hand muscles and the skin of the medial hand. Kwa hiyo tumesema median nerve innervate skin of the lateral hand in the anatomical position, but ulnar nerve innervate skin of the medial hand in the anatomical position. Then tukija kwenye radial nerve, travel along radius and innervates triceps brachii. You see, the posterior compartment of the arm, which is triceps brachii, is innervated by radial nerve. That's why in the humerus we have the radial groove. That radial groove, its function is to pass the radial nerve, and it innervates the triceps brachii and the muscles of the posterior compartment and overlying skin of the forearm. Posterior compartment and overlying skin. So axillary, this is radial. From there we have axillary nerve. Axillary nerve innervates the deltoid and the teres minor and overlying skin. So axillary nerve innervates the shoulder region. So axillary, shoulder region. Radial, posterior compartment. Ulnar, intrinsic muscles and the medial hand. Then median, forearm, muscles of the forearm compartment. Anterior compartment of the forearm, and then the lateral compartment in the anatomical position. Musculocutaneous, biceps brachii, and other muscles of the anterior compartment of the arm. So from there, you can see these branches, but we have discussed these branches many times. You can see how are they running along. This is ulnar nerve. Na unaweza kuona ulnar nerve inapita hapo jirani. Sasa kama huyu mtu, let's say kama it's the football player akipata injury kwenye humerus, kwenye pikonda ili hapa, the nerve which is most likely to be injured, it is ulnar nerve. Lakini unaweza kuona how the radial nerve passes posterior to the radial groove supplying the triceps brachii and then to the posterior compartment of the forearm. From there we have a median nerve which supplies the lateral compartment. We have the ulnar nerve supplies the medial compartment of the arm. Then the axillary nerve supplies the shoulder region. Musculocutaneous supplies the anterior compartment of the arm. So you can see this is radial and axillary nerve. tunaonyeshwa dermatons of the radial and axillary nerve. So axillary nerve kama unavyoona ni kwenye shoulder region. Huku ni posterior view, hii ni anterior view. Anterior view unaona axillary nerve ina kusupply, then radial nerve ina kusupply. Huku ni kuanzia hapa. So hiyo inaonyesha kabisa ni posterior. Unaona huku posterior ilivyochukua hapa kubwa. So ni posterior compartment. Ina supply hiyo skin yote, radial nerve inaenda mpaka huku chini. Lakini unaona radial nerve hapo impita kwenye anatomic snap box, lakini haijafika huku mwishoni. So tutaenda kuona nerves nyingine ambazo zitakuwa zina supply huku mwishoni. Lakini unaweza kuona muscular innervation. Kwa mfano unaweza kuona axillary nerve ina supply nani? Ina supply teres minor and deltoid. Teres minor and deltoid axillary nerve. Lakini kwenye radial nerve ina supply muscle nyingi. Bali tuitaje tu triceps brachii, but it is not only triceps brachii. Triceps brachii lateral head, triceps brachii long head, triceps brachii medial head. From there we have brachial radialis muscle, brachial radialis. Then you have extensor carpi radialis longus, extensor carpi radialis brevis, supinata, cutaneous. Then extensor digitorum minimi, extensor carpi ulnaris, abductor paralysis longus. All of these they are innervated by the radial nerve, and this is how the cutaneous nerve innervation can be seen. This is the muscular innervation, how the muscles they are separated by the nerves, but this is the cutaneous innervation. From there you can see this is for muscular cutaneous, median and the ulnar nerve. Muscular cutaneous, median and ulnar nerve. So the median, this is where muscular cutaneous nerve tend to supply. Muscular cutaneous nerve, as you can see, muscular cutaneous nerve here supply this compartment up to the thumb here. But you can see how here the median nerve start to innervate. It innervates the thumb or the posterior compartment, and some of the intrinsic, because this is what is seen here is just the cutaneous innervation. So this part, it is also supplied by the muscular cutaneous nerve, the biceps brachii, because you can see muscular cutaneous nerves supply the coracobrachialis, biceps brachii, and the brachialis muscle. All of these, they are muscles of this anterior compartment of the arm. From there we have the medial nerve. Medial nerve tend to supply the pronator teres, flexor carpi radialis, palmaris longus, then flexor digitorum superficialis, flexor pollicis longus, pronator quadratus. All of these, they are supplied by the medial nerve. Ulnar nerve supply the flexor carpi ulnaris and other muscles. So as we said, the ulnar nerve tend to supply the medial compartment, supply the medial compartment of the forearm, but the medial nerve tend to supply the lateral compartment of the forearm, that is towards the thumb in the anatomical position. So now let's move to applied anatomy. In all of these things we have studied, let's move to applied anatomy. In applied anatomy, we are looking for different deformities which can result in the injury of these nerves. Our first case to discuss is about the Erb's paralysis. Erb's paralysis. In the Erb's paralysis, the site of injury is the upper trunk of brachial plexus. Upper trunk of the brachial plexus. Now, if we are moving back and to see what the upper trunk resulted to, upper trunk or superior trunk of the brachial plexus. Unaweza kuona upper trunk ilipelekea posterior, then upper trunk ikapelekea lateral. Huyu hapa kadivide kwenda kwenye nerves zile pale. Huyu hapa kwenda naye huyu posterior medivide kwenda kwenye nerve mbili. Kwa unaweza kuona upper trunk au superior trunk ita affect kiasi gani? Unaona, it affect almost all nerves except this one. Kama it affect almost all nerves, that means most of the parts of the hand will be affected, because a certain part of almost all nerve will be injured, will be affected. Now we are saying that upper trunk of the brachial plexus, causes of the injury can be undue separation of the head from shoulder, undue separation of the head from shoulder. Kwa kama tuseme mtu amepata injury fulani imefanya mtu undue separation, labda mtu amepata trauma, amepata ajali ya gari, kwa ile purukushani ya ajali injure your nerve. So nerve roots involved from C5 and C6, and muscle paralyzed in a biceps to a deltoid, brachialis. Unaona biceps, brachialis, biceps na brachialis, huyu ni nani? Musculocutaneous. Deltoid huyu ni nani? Axillary nerve. Brachioradialis huyu ni nani? Radial nerve. Partially supraspinatus, infraspinatus and supinator. Lakini in terms of deformity ni position of the limb. Tunaposema deformity manake ni kwamba huyu mtu nini kitakuwa affected, ni position of the limb. Arm will be adducted and medial rotated. Adducted and medial rotated. Forearm extended and pronated. Extended and pronated. So the deformity is known as policeman's tip hand. Policeman's tip hand. Or it is called the Potter's tip paralysis. Potter's tip paralysis. Or in other words, it is EBC paralysis. And in terms of disability, what will be disabled here is abduction. Kama tusema arm itakuwa adducted, so abduction itakuwa inhibited. And the lateral rotation, medially rotated, arm itakuwa medially rotated kwenye deformity. Kwa hiyo arm itakuwa inaonekana medially rotated, kwa hiyo lateral rotation of the arm is lost. The flexion and supination of the arm is lost. Kwa manake extension and pronation ndio zimekuwa favored. Kwa kwenye muonekano EBC paralysis inaweza kaonekana kama hivi. Arm inakuwa kama hivi. This is how EBC paralysis can be seen. So sometimes in practical you can be given a chart like this one, and then you can be asked what is this and where the site of injury or what is the cause of trauma. However, it's not normally happens in practical. Our second deformity is krumpkas paralysis. Krumpkas paralysis. So again, this is paralysis. Paralysis, it is caused by the injury of nerves. So the site of injury is the lower trunk of a brachial plexus. Lower trunk causes undue abduction of arm. Undue abduction of arm. And the nerves involved is T1 and partially C8. Muscles paralyzed, the intrinsic muscles of the hand, ambao ni T1, and ulnar flexors of wrist and fingers, yani C8. Mkono utaonekani. What is the position of the arm in the deformity? It is claw hand. Claw hand. Position of the arm in the deformity is claw hand. So even if ambavyo unaweza kaona the krumpkas paralysis, how it appears, this is in the baby, and hii hapa inakuwa ni kwa mtu mzima. This is how the position can be seen, and it is called the claw hand. From there we have the median nerve injury. Median nerve injury. Median nerve kama tulivyosema ina supply lateral compartment kwenye forearm, na pia ina supply lateral compartment maeneo ya thumb. Sasa median nerve ikiwa injured, unapata kitu kinaitwa upper hand deformity. Upper hand deformity. Na kama unavyoweza kuona hii thumb hapa, maana yake unaweza kuona kabisa hii thumb jinsi ilivyokaa, kuna some of the movement zimekuwa failed, zimekuwa affected, and this is what we call the upper hand deformity. From there we have the injury to long thoracic nerve to serratus anterior muscle. So the long thoracic nerve is the branch of a brachial plexus, and is the nerve supplying the serratus anterior muscle. So if we injure this nerve, that means we will affect the function or the working of the serratus anterior muscle. Now causes is the sudden pressure on the shoulder from above. Kwa mfano mtu anaye carrying heavy loads on his shoulder, mtu anayebeba mizigo kuli, ile sudden pressure on the shoulder can injure the nerve to thoracic anterior muscle. and then what will be seen is we call the winging of scapula. Scapula inakuwa kama imenyenyuka, we call it winging of scapula. Disability is loss of pushing and punching movement. Arm cannot be raised beyond 90 degrees. So winging of scapula can be seen like this way. This is normal scapula, but this is winged scapula. Unaona ni kama vile imepanda, imeelevate, but this is the normal scapula. Unaweza hata usione boundary zake vizuri. So this is the winged scapula. So if unavyoenda kwenye exam, you will not meet with the question kwamba the injury to the long thoracic nerve will lead to, no, because tumeshajua hii inawapata nani, makuli. So unaweza kaambia kwamba a man carrying heavy loads sijui nini na nini, baadaye ukaambiwa complained of or ukaambiwa kwamba was found to have a maybe winged scapula, or a man carrying heavy loads complained of pain sijui nini na nini and the loss of punching and so what is the nerve which is probably injured, or you can be asked what is the muscle which is injured or which is paralyzed, or what is the feature of the disability, or what is the clinical presentation of the deformity. So you should know all this for your better performance of the MCQs. Also we have the radial nerve pass or injury to the radial nerve. A radial nerve injury present with the very important clinical sign which we call it the wrist drop. This is because the radial nerve supply the posterior compartment of the forearm, which is responsible for the extension of the wrist joint. So radial nerve pass or radial nerve injury, paralysis to the radial nerve, will lead to a wrist drop, because a person will be unable to flex the wrist joint, will be unable to flex the wrist joint. So this marks the end of our discussion about the nervous supply of the upper limb. To do a recap of the surface anatomy, we discussed the surface anatomy of all parts of the body, but we are doing a recap of the surface anatomy of the upper limb. As you can see here, we have the deltoid muscle. Here is the posterior axillary fold, then here is the anterior axillary fold, here is the axillary fossa. It's just like a fossa because of the regional ilikuwa hapa ndio inaitwa axillary fossa. Here we have the serratus anterior muscle. Here we have the deltopectoral groove. Kwa unavyotoka kwenye deltoid kwenda kwenye pectoralis major muscle, tunakuwa tuna groove pale. Then here we have the sternocostal head of the pectoralis major. You have the abdominal part of the pectoralis major. Kwa unaweza kuona kwamba hapa thorax ndio imeishia hapa. Huku tunakuwa tuna nini? Tuna abdomen. Kwa unaweza kuona surface anatomy kuna vitu vingi. We have clavicle pectoral, or we call it the deltopectoral triangle. You have the suprasternal or jugular notch. Normally it is called the jugular notch rather than the suprasternal notch. So just a part of our surface anatomy, as you can see: axillary fossa, anterior axillary fold, posterior axillary fold, deltoid muscle, biceps brachii, brachialis muscle below the biceps brachii, then median bicipital groove, or medial bicipital groove. Then you will have the lateral bicipital groove on the other side. You have the medial head of triceps brachii. Then you have basilic vein, which is passing here. You have the cubital fossa. Under the cubital fossa will have the median cubital vein passing through here. The median cubital vein, which is this vein passing through here at the median cubital vein, the vein which is very important in the drawing of blood in clinical procedures. So again, as you can see here, we have some of the numbers on in some of the NECTA atlas book. You can see the labeling for these, but here you can see the positioning and the labeling of the muscles. But again, remember, Some of the points, they are not discussed in this discussion. For example, this is the cubital fossa, triangle, cubital triangle, contents, median cubital vein, brachial artery, and median nerve. Median cubital vein, brachial artery, and median nerve. The important component is the median cubital vein, which is very important in the clinical procedures. But about the brachial artery, as I told you, the importance of the brachial artery is for taking blood pressure. When they are measuring blood pressure, they are taking from brachial artery. This is one among the questions which is most important appearing in the MCQs. That when a patient reaches in the hospital and the physician want to take blood pressure, what will be the artery from which the blood pressure will be taken? And the anatomical position of the brachial artery where blood pressure is taken is from the arm. Also, in the boundaries of the cubital fossa, we have the medial boundary, which is the parenteral muscle. Lateral boundary is brachioradialis, and the superior boundary is lying between epicondyles. So hapa haijaonyeshwa vizuri hii triangle because hizi epicondyle hapa, lakini in such unaweza kuona kwamba hizi zinaonekaneje. So yeah, from there unaweza kuona the anatomic snapbox. Tumeelezea sana kwa surface anatomy. We have the carpal tuner. Carpal tuner iko mbele ya mkono, then anatomical snapbox iko nyuma. So yeah, carpal tuner is not shown here, but it is also there, carpal tuner. And then in the clinical cases or in the MCQ, we have what we call the carpal tuner syndrome. Carpal tuner syndrome, and most especially the nerve which is affected in the carpal tuner syndrome is the median nerve, because the median nerve tend to pass below the carpal tuner. So if there is compression of the median nerve, you must know what will be the deformities in terms of median nerve compression, if a person gets carpal tuner syndrome. So also we have anatomic snapbox which contain radial artery. We are taking radial artery pass, or we are taking the pass of the blood pressure at the anatomical snapbox. We have the flow, the medial, the lateral. All these components you need to know them: the lateral, the medial boundary, the flow of each and every triangle and the component of the upper limb. This marks the end of our discussion about the nerve supply of the upper limb. Let's meet in the next session when we'll be discussing another part in the gross anatomy. Thank you, and later I wish you nice studies.